Very nice to see you. Very nice and pleased and honored that you have shared us this our Congress, and hoping that we will be together in the next years, and very pleased to be with us, and you will talk about a very interesting issue in Egypt, because someday we have hepatitis C virus prevalence is about 10% of all population, and the horrible number of liver cirrhosis, horrible number of varices, horrible number of gastric associated varices. So we will talk about a very interesting subject to us. So we are very eager and very interesting to hear your lecture. Please.
Well, thank you so much, Professor Akasha and the whole team for inviting me. This is very exciting to be able to discuss these things. And I love hearing perspectives, outside of our own institution here. I've learned a lot already in the first hour. So I am going to discuss an area that I've become very interested in, which is the role or application of endoscopic ultrasound to the management of gastric varices. And what I'll try to do is present to you the rationale, followed by the current evidence for EUS-guided therapy of gastric varices. And then I'll show in some detail how I perform this. And then finally, we'll talk about, complications and follow-up of these patients and the technique as a whole. And what I've learned as I got more involved in this field is that I needed to develop a deeper understanding of the portosystemic venous system. And so I'm going to review, which may be very familiar to those of you who deal with this, but it's something that I had to really pay attention to learn. And so in these diagrams, we're going to start on the top left. This is what is we expect to be normal portal circulation, where the splenic and superior mesenteric veins flow to combine to form the portal vein. This supports the liver and then connects through the systemic circulation through the hepatic vein and back through. Over here, we see what happens in the setting of cirrhosis. And most of my talk is going to focus on gastric varices due to cirrhosis. We do know, of course, they can be isolated in the setting of splenic vein thromboses, but I'm going to focus more on the more common variety. And here, what we see in the setting of cirrhosis is reversal of the flow back towards the splenic vein, and through what is normally not a very prominent vein, which is the left gastric vein. And here it's dilation or by this increased flow that leads to both esophageal varices, but also the possibility of gastric varices. Now, the other factor that affects our management of this is the development of portosystemic shunts spontaneously. And so here we can see such a shunt that's coming off the left renal vein that may also be contributing to the gastric varix as well. Further down, we can see contributions of both the the short gastric vein and the posterior gastric vein as well. So, in my head, when I, thought about gastric varices, I always imagined, this sort of picture. But as I've learned more about it, I realized that it can be quite complex, and understanding these relationships and connections really helps us select the proper treatment. Here we see just a final example. Traditionally, we've tried to manage portal hypertension by reducing the pressure within the liver by creating a shunt. And so this is an example of a TIPS procedure where the shunt is made between the systemic and portal system, and this allows some reversal or bidirectional flow at least to release pressure that's built up. So with that, those principles in mind, we move on to how do these correlate to the typical classification system we use in gastric varices? Most of you are, I'm sure, familiar with the Sarin classification, and I want to illustrate how those correlate to the underlying vascular anatomy we just reviewed. So we see commonly esophageal varices, and those esophageal varices, as they extend into along the lesser curvature of the stomach, These are referred to as gastroesophageal varices 1 or GOV1. And these you can see are predominantly fed from the left gastric vein directly off the portal vein. And so our approach to those typically is limited or is focused on banding, as most of you know, which is effective, highly effective for esophageal varices. And we really are just extending that along here to the cardia or lesser curvature to treat GOV1s as well. However, on the diagram on the right, we see the other varieties, GOV2s, which are really the most interesting because they can have dual etiologies. They can form off of the left gastric and behave similarly to GOV1s, and usually those are very much right along the GE junction here. But more frequently, they're fed from the short gastric or posterior gastric veins over here. And so these tend to be broader, wider based complexes compared to the more sort of linear ones that we see that are fed from here. And of course, if there's no continuity with the esophagus, these are called IGV, or isolated gastric varices, also coming off the system. And then finally, the true isolated type are sort of these random ones that can form from anywhere, including the SMV. And these can be very challenging, such as small bowel or duodenal varices. So I found it helpful to keep this framework in mind as we begin to decide how to treat these different scenarios. Again, just another diagram to illustrate the underlying supply of the varices and how that allows us a couple of things. So what we've learned is GOV2 and IGV1s, which are supplied not only from directly from the portal system, but have a connection here. You can see a systemic shunt going to the renal vein. These can bleed at a lower rate or lower portal pressure because of this dual supply. So sometimes we can overlook these if we're relying on traditional measures like portal pressure measurements and so on, or we may be surprised, why did this patient bleed when, you know, we didn't suspect such a advanced source of liver disease. Number two, when we are treating them, we have to be aware of these connections because as we, and we'll talk about as we inject, you know, traditionally a glue or cyanoacrylate directly into the varices has been practiced for a long time. However, we have to be aware of these connections because these connections are also what lead to the major feared complication, which is because there's a direct connection to the systemic system, anything we inject into here has the risk of directly traveling into the systemic circulation and back into, usually we worry about pulmonary embolus. And so that's another reason to be very aware of these. And then finally, we take advantage of these connections from interventional radiology. These are what they're going to use in their techniques to access the gastric varices. So by percutaneously accessing the systemic circulation, they can then thread their catheters and so on through these in direct treatment to gastric varices. So again, very important to have this basic framework in mind. So current recommendations for management of gastric varices, this is from the European Hepatology Society, EASL. Let's review those. First of all, they are common. 20% of patients will have gastric varices. It sounds like you're very aware of that fact in Egypt. In terms of primary prevention, the ones that tend to bleed at a higher rate are those that potentially have dual supply, which are the GOV type 2 and IGV1. So these are the ones that we really are, when we're thinking about management of gastric varices. We also are moving away from using the Sarin classification and talking more about cardiofundal varices. And those are the ones that correlate to this area as opposed to gastroesophageal varices. And that's sort of how I discuss them here in our hospital. So for primary prevention, it's not the strongest recommendation, just not a lot of data available. But if non-selective beta blockers are suggested for primary prevention, For gastroesophageal varices, it basically is the same recommendations as you would follow for esophageal varices. So it makes sense to think of them that way. In terms of acute variceal hemorrhage, again, it's the same initial principles, hemodynamic support, et cetera. And as you can see here, cyanoacrylate injection is recommended for control in cardiofundal varices. And this has been practiced for many, many years throughout the world. The role of interventional radiology through a TIPS shunt and with addition of embolization through percutaneous route does control bleeding and prevent rebleeding in fundal varices. And again, should be considered. And this gets a fairly strong recommendation. And at the time, this was published 3 years ago, selective embolization through the percutaneous route, these are procedures known as BRTO or BERTO, may also be used to treat bleeding fundal varices, especially those who have large collaterals. So, if you read this, it really doesn't guide us too much, beyond what we already know about esophageal varices. And what you see is there's no mention or role of endoscopic ultrasound. So I'm going to present to you the current evidence of the role of EUS in the management of these varices. And really the story began, or at least in the literature, in 2016, a publication from Ken Binmuller's group in San Francisco, where they presented the largest US experience with EUS-guided coil embolization. Here's a typical sequence. Here we can see, I'm sure what's a familiar view to you, large fundal varix. Under ultrasound, the varix is identified as anechoic tubular structures. It's very important to recognize the ones that are actually within the wall of the stomach, within the submucosa of the stomach. Of course, there'll be many collaterals and perigastric varices, and we want to resist the temptation to treat those and focus on the ones that are actually correlating to what you see endoscopically. Here's a view of a needle that's puncturing the varix, and through the needle, and I'm going to show you a video of this, through the needle, placement of a coil, usually multiple coils are placed. Here we can see a post-embolization appearance. You can see this change in the surface of the varix, indicating reduced or reduction of flow. Here under EUS Doppler evaluation, we see absence of flow. And then here, several months later, follow-up, you can see a dramatic resolution of that varix. So in their series, which was about 150 patients over 6 years, technically successful in almost all patients. They had follow-up in about 2/3 of these patients. And what they saw was a very high rate of obliteration of these varices, over 90%. A small percentage required either retreatment with the same technique or an alternative method. So based on this publication, this generated a lot of interest here in the United States to further develop this technique. Our institution here, our experience, initial experience here at Baylor St. Luke's over about 2 to 3 years ago. Here we published our results looking at 3 strategies for performing this procedure. As published in Binmuller's paper, the idea was to use a combination of coil and glue. However, we were curious to see how this compared to maybe just using coils alone, and then comparing that to our experience previously with direct glue injection. And what we found, or at least a suggestion of, this was a retrospective, is that recurrence of bleeding tended to be less in the combination therapy group compared to either single therapy group alone. This has been studied further in other groups. Here we see actually the first of its kind randomized trial comparing the use of embolization coils and glue versus coils alone. And before I go too much into it, I just want to explain the rationale here. So traditionally, cyanoacrylate is injected in the varix. It forms a plug to reduce further flow into the varix, and it then slowly dissolves or resolves. The problem was the amount of glue that could be required often carried a risk of embolization of the glue into the systemic circulation. So the idea here was to use coils to provide two functions. One is to occupy space within the varix, and also to provide what we call a scaffolding effect, so that when you apply, you can use a smaller amount of glue that fills the spaces within the varix to provide a similar plug, but reduce that risk of embolization of glue. And this has been the fundamental idea behind this technique. So in a randomized trial, this was done by Carlos Robles Medrano down in Ecuador. He compared 30 patients with combination therapy versus those with coils alone. And what we see here was a much higher rate of immediate disappearance of the varix. And how we assess that is by looking on Doppler flow, that the blood flow has disappeared. And you can see it was significantly more likely to happen when you're using cyanoacrylate, really to fill the spaces within the coils. In terms of rebleeding, there was also a significant decrease in the combination group. And in terms of varix reappearance, or perhaps a better way to think of it is incomplete obliteration of the varix, also significantly improved in the combination therapy. And if we look at a time to event analysis, blue being coils alone, green being the combination, again, we see a significant reduction over time in the need for re-intervention. So this supports our own experience here in Houston as well. Of course, once you had a few studies done, those who know or who are clever began to perform meta-analyses of the few studies to give us some information. And this is a very recent systemic review published by the Boston group. And here they were comparing, they took the available studies, about over 500 patients. Our own data was included in this meta-analysis, comparing the outcomes with, again, glue alone under EUS guidance, the combination, or coil alone. And what we can see here, I'm going to direct your attention to the subgroup analyses. And the takeaway message here is whether it's glue versus the combination, coil versus the combination, we always will have better outcome, whether it's technical or clinical success, lower rate of adverse events, and lower need for re-intervention in the combination of coils and cyanoacrylate. So this has really become, if there is a standard, this is what I would consider it currently. Finally, from our friend Doug Adler in Utah, also took a step back and said, let's compare all of these EUS techniques with the traditional way, just direct endoscopic cyanoacrylate. This was also done through a meta-analysis published this month, and large cohorts of both EUS modalities, as well as historical cohorts of just direct endoscopic glue. And again, what we see here is in terms of obliteration of the varix, a higher percentage in the EUS-guided therapies compared to just glue alone. Part of that has to do with the guidance you get from the EUS itself in terms of Doppler flow and visualization of the varix, a lower rate of recurrence and late rebleeding. And then in terms of embolization rates, the literature was very spotty on direct glue use, but in terms of the within EUS, the combination of coiling glue is superior to glue alone. So again, another some evidence to support that. So in terms of performing the procedure, how do we prepare for it? Because these patients are either bleeding or have high risk of bleeding, I recommend endotracheal intubation if available. Because we are going from the gastric lumen into the intravascular space in patients with cirrhosis, we provide IV antibiotics. In terms of equipment, we'll have an upper endoscope, which is what I'll begin with to do a standard exam. We'll need a linear echo endoscope for the procedure. I'll show you the needles. We typically will, in this case, we will use FNA needle. We're not taking a biopsy. And depending on the type of coils, which I'll review, we'll use either a 22 or 19 gauge. And of course, the coils, which I'll show you in a second. And we'll have cyanoacrylate available. Here, we use Dermabond, and we're not going to ever need to use more than 2 cc's. So I have a 3 cc syringe with it drawn up, ready to go. Multiple saline flushes. I do keep an injection needle nearby in case, kind of for rescue, if there's uncontrolled bleeding, we may perform direct cyanoacrylate injection. And in the event that there's concurrent esophageal varices that may need band ligation, we have a banding kit available as well. Here is the coil in magnified view. So these are platinum-based coils, and they are coated in these microfibers or hairs. And the idea is that these induce thrombus within the coil, or I'm sorry, within the varix itself, more so than just having a bare coil. And so by creating a network or a conglomeration of these, we can induce thrombosis within the varix and then glue to fill in any of the spaces in between. In terms of the coils, the ones we use come in 2 varieties. So there's 3 things to look at. One is the size of the wire of the coil. So I prefer to use, just like guide wires, they come in a 0.018 inch. They also come in a 0.035 or thicker coil. And then there's combinations of the length of the coil, when it's stretched out, and then what the diameter of the coil is once it's deployed. And you can see there's a number of a variety of combinations of these in terms of their lengths and diameters, and we choose them according to the estimated size of the varix. Here you can see the varieties that come in the 0.35 inch. So for 0.018 inch coils, we use a 22 gauge FNA needle. For the 0.35, you would need to use a 19 gauge. I'm going to show you how we prepare this. All right, so we're going to go over how to prepare for EUS-guided glue and coil embolization of gastric varices. So here's the basic supplies that we need. We need the needle as well as the coils. So for the types of coils we use in our unit, we're going to use a 22 gauge FNA needle to deliver the coils. The coils come in a variety of sizes, as you can see here. And the features of the coil to look at is the diameter of the coil wire. In this case, we're using 0.018 diameter. We also want to look at the diameter of the deployed coil once it comes out. And here you can see it varies between 6, 8, and 10 millimeters. And then finally, the length of the unraveled coil is listed here. In this case, we're using 7 centimeter coils. As I shared earlier, they come in a variety of configurations of these sizes. So my assistant here, we're going to go ahead and get started. You can open the needle, please. So for this, we're not aspirating, so I always put this aside to avoid any confusion. We're going to take the needle. And I like to begin by prepping the needle before handing it to the endoscopist. So the way to do that is we're going to require a saline flush. So while we get that, the basic idea is we're going to transfer the coil from its packaging from this catheter into the hollow lumen of the needle. So to begin, I'm going to remove the stylet. Okay. And we're going to always flush the needle with saline before inserting the coil. This helps prevent any friction with the coil as it's being deployed. Okay, and we'll see a little saline coming out. Perfect. Next, Susie, if you could open the 10 millimeter coil. Now it comes in 2 layers of packaging. It's important to note the contents of the package. So initially we'll have the coil, which is contained within this sheath catheter. And separately, there'll be a plunger with a round top. So you want to make sure you don't lose that. Susie's going to demonstrate how to take the safety wire out of the coil. Correct. Very good. Now the outer sheath is removed while holding the white. Okay. Now, the whole delivery system is going to be placed onto the needle. And it doesn't go all the way in, it stops there. And we allow the white lure lock to come down and we lock it in place. So currently the coil is stretched out in here. And now we're going to use the plunger to push it into the hollow part of the needle. As such. Then we simply unscrew the lure lock and remove. And now we're ready to advance the coil to the end of the needle. So imagine that the needle is inside the varix. And now using the stylet that came with the needle, we're going to push out the coil. And if you can take a close look there at the needle tip. So first we're seeing the saline being expressed from the needle. And as we advance the entire stylet, we'll begin to see the coil emerge right there. And as we push it out, you can see it beginning to take its shape. And as we push it all the way out, we get it within the varix. At this,
so that's
all right.
So that's just the basic way to prepare the needle. And let me pause this for a second. I like to have the needle prepared for the first injection outside, without attaching it to the scope. Each subsequent coil, the needle remains on the scope, the needle in the varix, and we're basically repeating that function with the needle on the scope. Here's the EUS view. Here we can see a needle puncturing a typical varix, and as that coil comes out, you can see it very nicely begin to take its shape within the varix itself. And the goal here is to fill, I really like to try to fill the varix as much as possible with coil in order to limit the amount of glue that's necessary. Once that first one is deployed, saline is always flushed in between. And now here you can see a final, we skipped ahead. And one technique we like to do is with the final coil is try to have it actually extruding outside of the varix. There you can see the needle was withdrawn into the lumen. What this does is creates a little bit of a plug within the puncture site and also allows us to easily identify where we have treated. Once that's been deployed, saline is flushed, the needle is reinserted into the coiled varix. And now we're going to inject a small amount of cyanoacrylate through the needle. And you'll begin to see, again, initially you'll see some saline, and then you see a hyperechoic substance that begins to solidify, fill in the spaces within the varix, and we'll see that here. You want to take your time, inject the glue slowly to avoid, again, embolization. And I use the visual to guide us. And here you can begin to see it emerging from the needle. And then we slowly withdraw the needle. Here you can see it filling up. And we slowly withdraw the needle. We like to leave the needle through the track for just maybe 10, 15 seconds to allow the glue to solidify. And that also helps plug the hole as well. And then we remove everything. And here you can see with the Doppler that there's no more flow within the varix. Okay. Endoscopically, so then I remove the echo endoscope and we'll re-examine endoscopically to assess for ongoing bleeding. And we'll take a look at that here as we switch to the endoscopic view. And here, done in retroflexion, we can see very clearly the extruded coil right here. You can see some of the extruded glue as well. And this varix has been nicely decompressed. Looks like there may be another one to treat down the road. I typically try to reserve to the largest one on the initial or the bleeding one if it's clear which one's bleeding. Additionally, we've expanded this outside of the stomach, and I'll share with you a case of duodenal varices. Much less common, but here you can see a patient who presented with GI bleed, and on exam he had these large duodenal varices located in the second portion of the duodenum. These can be challenging to manage. The patient had very advanced cirrhosis and was considered high risk for a TIPS procedure. So here we can see a nice view. Again, very important to note that the varix is within the submucosa of the GI tract, and a similar technique here. Once we identify under Doppler the targeted varix, we're then going to puncture with our needle right here. And it's very smooth, very easy to puncture. Through the needle, we're going to begin the coil deployment, and you'll see it take a very nice shape. We want to start sort of in the back end of the varix and work our way towards the GI lumen side and sort of filling in as we go. And here you can see a very nice coiling effect as the coil emerges. There is an advanced technique where the initial coil can begin outside the varix, sort of on this side, in order to anchor it. That is a little bit high risk in terms of causing intra-abdominal bleeding, but Mike Levy at Mayo Clinic advocates that to prevent migration risk. I favor just choosing the biggest coil I can possibly stuff in there to mitigate the risk of migration of the coil itself. Here you can see the image after multiple coils have been placed, this typical shadowing that we see. A little bit of residual flow, between the spaces of the coils, and this is what will get resolved with cyanoacrylate injection, which we're going to see here, filling in the spaces. And then finally, we can see there, and we're typically using between 1 and 2 cc's only for most of these cases. As we know, the embolization risk is correlated to the total volume. So this has really allowed us to limit that and minimize that risk. And here you can see at the end, I believe we'll run the Doppler over it to confirm, here we go right here, that we don't have flow in that varix. Very nicely done. So in terms of complications, in terms of bleeding risk, obviously you're puncturing a varix, everyone worries about it. I showed you one technique to reduce the risk is to partially deploy the coil outside of the varix. We do keep the needle in the varix, 15 to 30 seconds after the cyanoacrylate to plug the hole. Of course, have backup available if needed, whether it's a banding kit if you notice esophageal variceal bleeding, Blakemore tube, of course, and then, I recommend that these are done in an institution that does have IR available in the event for needs for emergent TIPS procedure. In terms of embolization, as we discussed, glue embolization can cause serious consequences like pulmonary emboli. It is related to the volume of glue. So really, I can't emphasize enough, it's the initial coil selection. If you select a very small coil in a big varix, it itself, I've seen this happen, it itself can embolize directly. We recently reviewed a case in GIE of an embolized coil to the right ventricle. I really try to use the largest coil that I can fit into the varix using the estimated size. Again, we talked about a technique to anchor coils as well. But between selecting the coil size and limiting the amount of glue, the dreaded risk of embolization, I think, is very much mitigated by this technique. Finally, I'll end with a couple things. In terms of follow-up, my routine is to repeat the endoscopy with ultrasound in 1 month to assess for any residual flow in the treated varix or any adjacent untreated varices. Subsequently, it's about 6 months. And then if it looks obliterated, they usually return to their hepatologist for their normal schedule. And we do treat, as I just said. So future directions for this field, there is interest in getting rid of glue completely and looking at non-glue injectates like gelatin or foam. There's an idea of using self-expanding plugs that would fit the size of the varix. We have a very good IR group here, and we've worked together on treating some very complicated varices, such as in the small bowel, or ones that have multiple systemic shunts, and working in combination to treat these safely. Of course, I think there's always been this hope that EUS can be used to develop a TIPS-like shunt in the liver. I know that is still kind of out there. And as we get comfortable with treating venous bleeding complications, there's also an interest in applying EUS to arterial therapies as well. And as Dr. Rothman referenced earlier, this all falls under this idea of endohepatology and having experts in managing or using endoscopy for all aspects of hepatology. As you may be aware, there's a new device available for portal pressure measurement done through EUS, and we touched briefly on liver biopsy as well. So with that, I'd like to thank you again for inviting me to this beautiful course, and I look forward to any questions from the audience. Thank you.
Thank you, Dr. Kalpesh, for this nice, elegant lecture. Actually, I have more than questions.
I have so many questions.
تفضل دكتور مازن بيه. تفضل دكتور مازن بيه.
First, is there a proof for saline classification that there is communication between GOV1 and GOV2 and the esophageal varices?
I'm sorry, meaning is GOV2 always connected to
GOV1 and GOV2, is there any proof that there is communication between these two varices, types of varices, and the esophageal varices?
So for GOV1, certainly because they're coming off the same, typically off the same left gastric vein, which provide the esophageal varices. So those I think are clearly associated. GOV2, I'm less convinced. I think that's why we're moving a little bit away from the sarin classification for those and classifying those more as just cardiofundal varices and approaching those with techniques related to that.
I injected all over my life. My main job is to inject the varices.
Yes.
When I inject what's called GOV1, I have never seen the histoacryl with lipidol going up to the esophagus. While if you inject above the Z line, you get the whole varix filled with histoacryl. And this is against the GOV1 is communicating with esophageal varices. Also, Sarin, in his paper, said that you must treat both sides separately. And if you didn't inject, if you didn't treat the what he called GOV1 and treat esophageal varices, then we will have recurrent. I'm against Sarin classification since 1988 because it has no basis.
Yeah.
And what is the difference between IgV1 and GOV2? It is the same. It is the same gastric varix.
Right.
Second,
go ahead.
The problem that we lost a lot of patients by this classification. I use the Carolla classification because it's more easy.
Mm-hmm.
And if you treat esophageal varices and don't realize that there is what we call by Carolla junction varices,
mm-hmm.
a lot of patients bleed, and those patients are stratified as they are bleeding from portal hypertension gastropathy. Because if you didn't see the bleeding from the junction varix, you didn't realize if it is a fold or the varix. So we must look very carefully to what Carolla called junction varices and Sarin called GOV1. And we must forget that there is a communication actually between GOV1, GOV2, and the esophagus.
Yes, and I agree with you. I've come into this field kind of not from, I didn't treat a lot of gastric varices prior to looking at EUS, is kind of how it came to me. I'll be honest, if I see GOV1, what we traditionally call GOV1, GOV, I don't really have much of a distinction in my head. I really approach those as,
I want to add to that, to Dr. Naga, because when we do EUS, the way we look at the varices is totally different. What we really see is the main thing is this penetrating vessels that just go through the wall and spread up and down. And mostly, the gastric one or spreading, esophageal. I didn't see in a penetrating one in the esophagus. I don't know, Cal, if you see this penetrating one. You mainly see them below the GE junction. And I feel like it could be, and this could be, but that's my guess, that it start gastric varices and they expand a little bit above the GE junction. And maybe that's why we were thinking it is esophageal going to the stomach, but it could be gastric extending up and dilated vein. But that's a theory, and I have no proof for that.
There's a mistake. Usually, if the esophageal varix is large, it usually prolapses below inside the cavity. But we must look at the Z line. This is a problem. You must look at the Z line. If the varix is covered by esophageal mucosa, this is prolapsed esophageal varix inside the stomach. If it is below the Z line, this is the junction. I'm trying to publish this since 1988. I said to my colleagues, I tried to publish even in Mickey Mouse. But now it is accepted last week.
Very nice.
I will show you the photos of what I am saying now. Second, the problem with histoacryl is not the amount. The problem is that injection of a large amount. We must not inject more than half an ampoule each injection. And the speed of injection is very important. And to wait at least 2 to 3 minutes between each injection, because even large varices can be injected by maximum 3.5 centimeters of the glue. The problem using large amount, the speed of injection, the dilution. And the morphology of the varix is variable. The problem that we have a lot of morphology. I speak about several types, the spherical type, the grape-like, which is very difficult to inject. And I said to my colleagues, you must send this patient to expert, because how to identify the limits of the varix is very important. And this is very important issues in injecting gastric varices, the morphology. The size is not important, because what we see from outside is not the real size of the varix. Some varices looks very large, and if you inject one ampoule, it's full of histoacryl. Another comment that gastric varices, isolated gastric varices, are found in patients with cirrhosis, not only in patients with left-sided portal hypertension, as written in most of the publications.
Thank you.
Thank you for those points. I was recently on writing the AGA guidelines on management of gastric varices, and this was a hot debate between endoscopists on the paper versus the hepatologists on the paper. And I think now that we look at these differently, as Dr. Rothman indicated on EUS, I think we have a more accurate assessment of their morphology.
Yeah.
Dr. Kalpesh, thank you again for this nice lecture. As you know, we have 4 categories of EUS view of fundal varix. We have peri, paragastric, and we have submucosal varix, which we are targeting endoscopically. But what your experience about injection of perforators?
So I have not spent a lot of time trying to target the perforating vessels, to be honest with you. And one of the reasons is unless you have at the same time, a detailed venography to really see the entire network, it's not clear to me that how do I know which one I'm selecting is going to be the one that's going to resolve that varix. So my bias is, I like to treat the end result which is the varix itself, treat it as well as I can, regardless of, because we've learned that some of these can be very complex, as you've already discussed, in terms of their multiple sources of flow. So I have not, I've been tempted to do that. Sometimes you see it very nicely and it's accessible, but I worry that it may overlook. Now, if you want to do it in combination with the varix, I think that's okay, but that may be overkill. But I think we have a lot to learn there still. One idea we've had is using maybe real-time venography, under fluoroscopy during the procedure to try to get that sort of map laid out and before selecting where to target. That may be an interesting next step.
There is a comment here. It is the time to remember late friend Locteo, whose dream was to come to Egypt to try to find the perforators.
Okay, Dr. Kalpesh, another question, please. What are the factors which you are determining the proper size of coil? As you said, it is regarding the size of varix. It is the same size of varix or just 1 or 2 millimeter bigger than varices?
Right. So unfortunately, even though there's 3 dimensions of the coil, none of them match 1-to-1 with the dimensions of the varix. So unlike a biliary stricture where you measure 3 centimeters and you have 3 centimeter of stent, here the final coil size, the 3-dimensional size, what we would really like to know, and I don't have this, is what's the volume of the coil versus the volume of the varix, right? Because that's what we're ultimately treating. We're treating a volume, not a linear size. So my preference has been, I do use the 0.018 wire because I find the 22 gauge needle allows me more flexibility during the procedure, and they're a little bit easier to pass. We use I showed you a 7 centimeter, but we use a 14 centimeter length coil as the initial coil. As long as the varix is more than 3 centimeters, I'll begin with that. And then it's really based on the appearance as you place each subsequent coil. So you'll do 1 or 2 of those, and then as you work towards the GI lumen, typically we'll select a smaller one to fill it in.
Okay. Dr. Mazen, do you recommend if we trial of multiple injection of endoscopically of fundal varix with non-success, do try in EUS trial, or we always recommend endoscopical injection?
The problem now, we have so much gastric, no varices even, so much varices now in Cairo. So how can you do this? In my opinion, the problem in gastric varices is the experience, how to teach the others. I was giving this lecture in Cornell in 2003. And I don't remember the name of the professor. He was astonished from the data I was presenting. And he asked me why you didn't present this to the DW. I said, I failed several times. He promised to help me, but there was no help when I sent to him. I didn't receive any comment. Now we have no varices actually like before. I was in my unit in Cairo University. The emergency was from 10 to 15 emergency patients per day. Now I think we have 2 or 3 emergencies per week maximum. And gastric varices represent, in my opinion, around 15-20% of gastric varices. So if you see 20 patients, you will find small number of gastric varices we see now is so low compared to before. And I was injecting 3 times per week in Qasr al-Aini from 1985 to 1998. I was having 3 sessions. Each session, I was having alone 20 patients. Now I see 1 patient per year now. HCV disappeared.
Yeah, In this country, you know, we have our own epidemic, you know, with fatty liver disease. And so we are still, you know, seeing a steady rate of these in a different patient population. And we're beginning to learn, we're trying to learn, you know, in non-viral hepatitis, what are some of the risk factors for gastric versus esophageal variceal bleeding.
I want to add something for endoscopic versus EUS, because I did both. And honestly, I was doing the endoscopic one. I would see in most of the cases, if you're going to do EUS guided, if you're going to do endoscopic guided and it is nice shape and is not bleeding, it's fine. But there's one situation that I found that EUS guided would be best, which is when you have active bleeding. Because with active bleeding, it's easily to go by EUS. You don't worry about anything. You can put the coils.
No. It is very easy during bleeding. The problem is that you put the patient on his face and raise the table so his head up, so the blood will trickle away from the fundus and you can see the fundal varix very easily. The problem, we have a lot of experience, but we have no chance even to give a lecture about fundal varices. The only chance I have was in Cornell in 2003 by the invitation from Professor Thruli. And there was at that time Gregory Haber, and he said he has nothing to add after my videos. And the problem, no one gave us a chance to present our experience. I have the paper, the rejection of the paper 1988, and I said to Professor Thomas Roche, you send the paper to people who have never seen a varix. So the rejection was completely on no basis.
Okay, then thank you very much. I think you are now short of time. Thank you very much, Professor Mazen Naga, Professor Kalpesh Patel, and Professor Muhammad Osman for the very nice debate. And